My name's Allison Stewart. I'm a nurse practitioner who works with pediatric surgery, and I'm here today to teach you about the gastrostomy tube that your child is either going to have or has already had placed. So what is a G-tube? Well, G-tube is an intervention that we use to help supplement feedings. Some children are unable to take oral feedings, or sometimes they can take some oral feedings, but they're not taking enough feeding orally to be able to support their caloric needs. And so that's what the G-tube is for. Sometimes they are used exclusively, and sometimes the baby will feed some orally, and then whatever formula the baby is unable to take, the rest of it will go through the G-tube. So the first thing we want to do is make sure that before you touch the G-tube or the baby, that you always wash your hands. It is important to wash your hands and keep down on any type of transmission between yourself and the wound site. So first thing, washing your hands in soap and water. Second thing I want to talk to you about is what the G-tube is and show you what it looks like. So this is the G-tube, okay? The parts to the G-tube, you have the retention balloon port, you have the feeding port, you have the feeding port cover, and we fill the retention balloon with water. For purposes of this education video, we're going to use air, but usually about 5 cc's of air, or milliliters of air, is what is the balloon, and that's what holds the balloon in place inside the baby's stomach. Okay, so this is what it looks like inside the baby's stomach. For purposes, just so you can see what it looks like from the inside. Now, when you feed your baby with the G-tube, there is going to be a feeding extension tubing that you will put into the G-tube. So this is the feeding extension tubing. This is the feeding port. It's a 90-degree secure lock port. This is the feeding port that you would attach the actual feeding tube to this port. This is the medication port, so if you have medication to give, you can place it in this port, but usually that is closed unless you're using it. And then you have the clamp that you can open and close, and that's what controls the formula going down through the tube. This feeding extension tubing is going to be attached to the G-tube when your baby comes back from surgery, and it's going to stay in place for 2 weeks. And after that 2 weeks is up, then you can take the feeding port off and then only use it when it is feeding time. The reason why we keep the feeding port attached is to decrease the amount of manipulation to that fresh G-tube site. So there is a black line on this feeding port extension tubing. There is also a black line on the G-tube, and there is a little plastic notch, and there is an area on the G-tube for the plastic notch to fit into. So you're going to line those things up and push down, and then you're going to turn at least a quarter turn, but you can turn all the way. If you think about this as a clock, this being 12 o'clock, you can turn all the way to about the 11 o'clock, 10 to 11 o'clock position before you meet resistance. When you hit that point where you reach resistance, you do not want to turn this extension tubing past that area. That's considered the lock position. But at the same time, it can move a little bit, but that is considered a lock position. And the reason why you don't want to turn that past that point of resistance is it can damage the anti-reflux valve that's inside the tube. Okay, so now we're going to talk about the best way to clean and care for the actual G-tube itself. So the most important thing is to flush it after every feeding. Every time you put medication down it, anytime you use the tube, it is important that this feeding extension tubing is flushed with at least 5 milliliters of water, somewhere between 3 and 5. Basically, whatever amount of fluid it takes to clear this tube is the amount of fluid that you want to use. So after your feeding is complete, you're going to use some water. For these purposes, we're just going to use some air. We're going to attach that catheter tip in there, and this would be with water. And then you're going to instill the water, and it goes through, clears this tubing of any formula or medicine, and what that does to the tube itself is it clears the anti-reflux valve that is right at the top of the inside of this feeding port. And by doing that, you remove some of the formula buildup, medicine buildup, so that those two pieces of the anti-reflux valve can remain flush and touching together. That's what keeps any gastric contents from coming back up through the hole and then coming out of the tube itself. So that's the most important thing in taking care of the G-tube itself, is making sure you flush after feedings and giving medication. The other thing that you can do is if you see any buildup of formula just sitting inside of here, since this hole is a little small, Q-tips don't always fit down inside of there, but what you could do is use your a piece of gauze, and you could wick it or twist it like a wick, and then you can put it inside of there and clear up any formula or anything that you see inside of there, because we want to keep this area clean and dry. Once again, to decrease any buildup on that anti-reflux valve so that it is able to stay closed. Now we're going to talk about skin care. So right now, or after the baby initially comes back from surgery, there's going to be a thick duoderm dressing around the G-tube site, and there's going to be a piece of gauze with a clear tegaderm covering over the umbilicus, over the belly button. And that dressing will stay in place for 48 hours after the surgery. Then they will take that thicker duoderm dressing off and also take off the tegaderm and the gauze, and it will be replaced with a split 2x2. This is a split 2x2. In the package, they come two in a package, so you can use both of them together, or you can use just one. It kind of depends in this post-operative period on how much swelling there is in the area there and how many will fit underneath that site. So after surgery, you're going to expect that there's going to be redness, there's going to be swelling, there's going to be drainage just from the tissue that during its healing process, it's going to there's going to be some fluid that comes from that area. But at the same time, once you hit that post-operative period, about 2 weeks out or so, that area is going to start to heal and it's starting to change. And so when you're looking at the baby skin every day, you want to get used to what the normal look of that G-tube site is, and that way you will be able to identify more easily when it is not normal. So once again, some of the ways that it's looking right now Postoperatively, those are the things we want you to pay attention to after it heals. So that would be increased redness, swelling, tenderness to touch. And what I mean by that is when the G-tube is in place and you're accessing and de-accessing with your feeding tubing, you want to make sure that you hold on to it so that when you are accessing and de-accessing the feeding extension tubing, you're not just pressing down on the baby's skin and on their stomach. You want to hold on to it so that you're stabilizing it as you are accessing and de-accessing. But sometimes the babies will let you know that they're uncomfortable by that action. And so that's what I mean by the tenderness or some pain when you're accessing and de-accessing. They really should not be uncomfortable when you're performing those movements. If you notice any drainage that is green or thick yellow, if you notice any bad odor at the site, those are all signs of infection. And if you're noticing anything like that, we want you to call our office right away and let us know so that we can have you come in and be seen by Dr. Kumar. So that's the first thing, is inspecting the skin around the site and making sure that you're not noticing any of those signs of infection. When it comes to cleaning the stoma, you're just going to use a warm washcloth with some mild soap, and you're going to clean around there. You could use just a wet washcloth with water and clean around there. Sometimes people like to use Q-tips to clean around. And while you're cleaning, you're going to be moving the G-tube itself so that you can get all around the site. So as you're doing that, you are kind of rotating. So there's no reason to do an actual daily rotation of the tube, because while you're cleaning that site on a daily basis, you are actually turning your tube around so you can get all the way underneath and clean well. So let me blow the retention balloon back up so that you can see what the split 2x2 looks like. This is the dressing you'll have when you go home. We had mentioned having the feeding extension tubing attached for 2 weeks after surgery, and so that's going to look like this. While your baby's in the hospital, they will be using what we call a FlexiTrack, and the FlexiTrack is just an attachment that goes on the skin and holds the tubing in place. Okay, and then you don't have to worry about that. You just need to be sure that this isn't being pulled too tight, that it's not pulling the feeding tube down, that the attachment just is straight up and down without any pressure anywhere. The reason why we continue to use that split 2x2 is so that we can keep the wound clean and dry. We don't want there to be any buildup of drainage, wetness, soiling, anything on here. If you notice that, then please take this off and replace it with another 2x2. There isn't necessarily a scheduled time for changing these 2x2s. We just want to keep that area clean and dry. So if it's wet, if it's soiled, then it needs to be replaced. Now, sometimes there can be just a little bit of redness around the site of the G-tube, and that is because our skin is not made for the acidic contents from our stomach. And this is a hole here, so there will be some leakage that comes from that hole. It would be an unrealistic expectation to think you would never see any drainage of gastric contents coming from this hole, because it is a hole. But you want to try to keep this area as clean and dry as you can with the use of the 2x2s. But if you notice that there is some redness around this area here, and that you've noticed a little bit more drainage on your 2x2, then you're going to want to use a barrier cream around this site. So think about it like when your babies have diaper rash. We can't stop them from using the bathroom, but we can protect their skin from the contents of their stool. And it's kind of the same thing here. We can't stop all of the leakage, but what we can do is protect the skin. And the way that we do that is with the barrier cream. Zinc oxide creams such as Desitin, the same thing you would use for diaper rash, is a very good barrier cream. There's also another barrier cream called Calmacetine that you can buy over the counter at Walgreens and Walmart, and it's a very good barrier cream as well. So if you're noticing that redness, that may be from gastric contents and the acidity that comes along with that, then you're going to want to put some barrier cream down on the skin, and then you're going to want to put your 2x2 on top of that. But most definitely, if there is any concern about the way that the site looks, please do not hesitate to call the pediatric surgery office. Once you get to the point where the baby is not having any leakage and drainage from the G-tube site, then you do not need to continue to use the split 2x2s or any other dressing around the area. That it will occur. It may not be within the first 3 months after surgery, but that time will come where you'll see very little drainage from the area. So when that time comes, then there's no reason to continue to use the split 2x2. Now I want to talk about appropriate fit of the G-tube itself. We don't want the tube to fit too tight, and we don't want the tube to fit too loosely. If the tube is fitting too tight, then we may run a problem of denuding the skin or rubbing that skin raw where the G-tube is. If the tube is too loose and we're getting more gastric contents coming from around the G-tube site, then once again, we're having problems with skin at that point, irritation that can lead to skin breakdown. So we want to be sure that we have the right fit or the appropriate fit. So the appropriate fit would be about 3 millimeters in length that you're able to actually visualize. So I'm going to blow this back up. This is the bottom of the G-tube, and we want the bottom of the G-tube to have about 3 millimeters of space between the bottom and the top of the skin. If you think about the size of a quarter, and being able to slip a quarter in between your baby's skin and the bottom of this tube, that's about the amount of space that you want to have. You should be able to see a little bit of this white line. And as long as you can see a little bit of that white line and you're not noticing that the skin is building up around the balloon, so it kind of looks like this, almost like the G-tube is buried into the skin, that most definitely is a fit that is too tight and not appropriate, and setting ourselves up for some skin breakdown there, okay? So just think about a quarter, and do you think that you could slide a quarter between the bottom of this and your baby's skin, and can you see a little bit of this white line? And that lets you know that your fit is appropriate, okay? Now we're going to talk about decompression or venting. Another term for that is also called burping. And what you're going to do is, after the baby has had their feeding, then you wait about 20 to 30 minutes and see what their comfort level is. Sometimes they might get a little fussy. You may learn that your baby needs to be vented immediately, after they're feeding. You're going to do what's comfortable for the baby. But what we're trying to do is let excess gas escape, air bubbles escape. So if your baby is doing oral feedings first, and then you're feeding the rest through the G-tube, depending on how much is going through the G-tube, you may not need to vent very much because you're probably burping when you're doing your oral feedings. For babies who are having all of their feedings go through the G-tube and aren't taking anything by mouth, then using the venting method is probably going to be more effective. So I will show you what that looks like. While you're here in the hospital, you may see nursing staff venting after a feeding. So your feeding tube extension is already in place because you just got finished doing a feeding. And you're going to want to initially have your clamp closed and make sure that your medication port is closed, because formula can come back up, and instead of being in the control of your syringe, if this is open and you open up this clamp, of course the formula is going to take the path of least resistance and is going to roll out here instead of coming up, and you're going to lose your feeding. So make sure this is closed, and you can hold this while you have your baby upright. You can hold this up, and so formula and sometimes bubbling, you might even hear some air bubble, come up into your syringe, and you can bubble them for about 10-15 minutes. And then after that, if formula has rolled back up into the syringe, usually by that time it equalizes and it kind of rolls back down by itself. Sometimes it may not roll back down by itself, and you just give a little push with your syringe. After the 10 or 15 minutes, the formula goes back down, and don't forget to flush after that. But that's decompression, burping, venting, all mean the same thing. You're just trying to get air bubbles from the baby's tummy. So now I want to talk about some minor complications that will need minimal or even no interventions. Parents seem to be most concerned about leakage from the G-tube site. And as I shared with you before, that is a hole that we've created, and with the balloon that sits against the stomach wall, that does keep a lot of leakage from happening, but you're still going to see some. Whatever leakage you notice on your 2x2, as long as your 2x2 is handling whatever leakage, then that's appropriate. You're not having necessarily too much leakage if your 2x2 can handle it. If the leakage is such that it is leaking through their clothing, then that is entirely too much leakage, and you need to call the office, the pediatric surgery office, and let us know that you're having an excessive amount of leakage, because that's kind of counterproductive of what we're trying to do. We don't want so much formula leaking out that the baby is losing calories and they're not getting their nutrition. So if there's just a little bit on your tube, on your 2x2, that's fine. If it's so much that it's leaking through their clothing, then we need to know about that. Okay. So what are some causes of leakage, and how do we address those things? So one of the causes of leakage has to do with the volume of water in the balloon. As I explained to you earlier, there's about 5 cc's of water, 5 milliliters of water in the balloon. That's what causes the balloon to sit up against the stomach wall, and it does decrease leakage. Okay. Sometimes you may find that instead of just seeing that small amount of the white line, that you're noticing that the balloon is fitting more loosely, and maybe you're even seeing more of the white line than you were seeing before. And so if that is the case, it very well may be that your balloon has lost some of the water that's inside of it, okay? And so if that's the case, let me back up a little bit. First of all, if there's any problems with your G-tube in the first 3 months after having the G-tube surgery, and we haven't performed the first G-tube change, which happens 3 months after surgery, if anything is going on with the G-tube that you are concerned about in that time frame, those first 3 months, we really do want you to call the office, because we want to be really hands-on with that G-tube in those first 3 months while we're waiting for that tract to mature, okay? So these volume checks that I'm talking about isn't anything that you're going to be doing within those first 3 months of having a new tube. This isn't anything that you would do. This isn't anything that you wouldn't. You would perform the volume checks after we have already made the first G-tube change, if they are necessary. Okay. So let's say you're noticing a lot more leakage than what you had before. You call the office, and you say, you know, we're seeing a lot more leakage. The first thing we're going to ask you to do at that point is to check the volume in the balloon, okay? So once again, this is after the first 3 months. So you're going to check and see how much water you have in the balloon, and let's say you know there was supposed to be 5 in there, but there's only 3 milliliters of water. So we would ask you to refill to 5. So you would put 5 milliliters of water back in your syringe. You're going to put that into the retention balloon port, put that back in, and then we're going to ask you to wait about an hour and a half or so, and then go back and check your balloon volume again. If you have the same amount of water, the 5 milliliters is what you get back, then we know pretty certain that there probably isn't anything wrong with the balloon. It very well could be that some of the water just evaporated. If there is a lesser amount now, an hour and a half later, 2 hours later, then we know that there's something wrong with this balloon. It maybe has a slow leak, something is defective with that balloon. We're going to have to change the G-tube at that time. And when we change the G-tube, it is not a surgical procedure. And since you would have already seen that G-tube change one time, then you know that it's as simple as taking all of the water out of the retention balloon and then getting your new G-tube, placing it inside of the stoma area, and then refilling it with water. So, but checking the volume, and that's going to be one of the interventions if we're seeing more leakage from the G-tube side. The second thing that can cause more leakage is granulation tissue. Granulation tissue is normal healing tissue, the same way when anyone gets a cut and our tissue knits and heals together, that's by granulation tissue. So we've created a wound here for the baby, and the body is doing what it's supposed to do. It's trying to close that hole. It just so happens that we want this hole to stay open. So with that new tissue that is growing there and a new blood supply that is growing there to bring nutrition to that new tissue, this tissue can be, it is very vascular, and if the tube happens to bump up against that granulation tissue, it can cause a little amount of bleeding. So sometimes what families notice first is a little bit of blood on the 2x2, or they are noticing that there's a pink budding type tissue coming around the G-tube site itself. The reason why granulation tissue causes more leakage is because granulation tissue very seldom comes in the same way all the way around that site. If you think about the site as a clock, granulation tissue sometimes will grow maybe from 12 o'clock to 4 o'clock, and maybe the rest of that G-tube site area doesn't have any granulation tissue at all, or that area, the granulation tissue may be thicker than in the other areas around the G-tube site. So that keeps the G-tube from fitting flush up against the skin. It kind of sits a little off because of the granulation tissue. So of course that can cause more leakage. There are two ways that we deal with granulation tissue. You're going to want to make a phone call to the office and let us know that you're thinking your baby maybe has some granulation tissue. And when they come into the office, we will use a chemical stick called silver nitrate, and we will cauterize or destroy that growing tissue around the site. That is the main way that we handle granulation tissue initially. And then after that, we can use a topical steroid called triamcinolone cream, and you would apply that, actually not just apply, but massage, either with a gloved finger or even with a Q-tip, and you would massage that into the area of the granulation tissue, not just lay it on there, but massage it into there. And you can do that 3 times a day for up to 14 days. We don't want you to use that cream any more than the 14 days because the same reason why it resolves the granulation tissue by thinning out the skin. If you use it longer than the 14 days, then we can start to damage the skin. So only for 14 days. But hopefully you'll be in contact with the office during this time, and we can check back with you, or you can call us back and let us know what kind of results you're seeing with the use of the triamcinolone cream. So, volume in the balloon, granulation tissue, 2 reasons why you can see more leakage. Third reason why you can see more leakage has to do with any increase in pressure in the tummy. And that would come from coughing. So if the baby happens to have a cold and they're coughing a lot more, you're going to see more leakage from that area. If they're doing sneezing, once again, increase in intra-abdominal pressure, you're going to see more leakage because that fluid's going to take the path of least resistance, and that's going to be out of that hole. If your baby has been vomiting, you're liable to see more drainage with that also. For some children who are on vents, the increased intra-abdominal pressure that comes from being on a vent can cause more leakage to occur also. And so those are things that we really can't do anything about. We just need to support the child and the area. We might need to change our 2x2s more frequently. If at all possible, we might need to use more than 1 or 2 2x2s and try to support that area a little better there. If we're seeing irritation because of the increase in drainage, then we need to support the skin by using barrier cream. But there isn't anything to do until the child gets better. They're not sneezing anymore, they're not vomiting anymore, they're not coughing anymore, those types of things. Then one of the other things that can cause leakage from the stoma is if there's been any loss in weight. Usually that's a late sign. Most often these babies are getting weight checks frequently, and so you know when they're losing weight. But if there is a loss of weight, then you're going to see an increase in the length. And instead of seeing a small amount of your white line, you may be seeing, quite a bit more of your white line. So once again, this balloon is going to get more loose. It's not going to fit as snug as it did previously. You're going to have more leakage, and that can be because of weight loss. Okay. One of the things that parents get really excited about, and for good cause, is if the G-tube were to come out, okay? And so, as I shared with you before, the only thing that's keeping this G-tube in place is the water that's in the retention balloon, okay? So if there is a problem with the retention balloon, such as a slow leak or water has evaporated from it, and we don't have the balloon holding it in place, then of course it can come out. So if this were to come out, tube dislodgement is what we call it. If the G-tube were to dislodge within the first 3 months of having the surgery, the tract is not considered mature at that point. So we want, the first thing for you to do is call the pediatric surgery office. If we happen not to be in the office because it's after hours, stay on the line, listen for the phone tree option of the answering service. Tell them you want the dial whatever option for the answering service, and let the answering service know you need to speak to the surgeon on call. And then speak to that surgeon on call, and they will let you know what they would like for you to do, okay? But you won't be able to replace the tube yourself if it's within these first 3 months and they haven't had their first official tube change. Usually we have you come to the emergency room, and it is replaced in the emergency room. And the reason why we need to do that is because we need to check it and verify placement by a test in radiology, where they put some dye through the G-tube and make sure that it is actually in the stomach. So you should have a backup G-tube at home at that time. And I want you to take your backup G-tube with you, but don't offer it when you go to the emergency room. If we have them here in the hospital, then let us use our supply. If it just so happens that we don't have that tube in the hospital, then please go ahead and offer the use of your tube. But just make sure that you have the tube with you, but let us use our supply. So if you notice that this tube has come out, all you need to do is take a 2x2 and fold it, put it over the stoma, tape it, and drive yourself safely to the hospital, okay? It is not necessarily an emergency, but it is urgent that you get here. In the first 3 months, while that tube has not matured, it can start to close within an hour. So, like I said, it isn't an emergency, but it is urgent that you get here. We don't want you hurting yourself trying to get here. We don't want you running red lights. We just want you to get here as soon as you can and safely, and then we can take care of the G-tube once you and the baby arrive to the emergency room safely. The last thing for us to talk about is administering medications. Most medications are liquid anymore, so there's no problem with administering them. You want to be sure that you do not mix your medication that you're administering with your feeding. You want to give the medications one at a time through the medication port. So once you have your feeding extension tubing attached, you can put, if you're done with your regular feeding, then you're going to want to do a water flush, and then you can open up your medication port and administer your medication. And if there's more than one medication to administer, you're going to want to flush in between each one. So you can use a small amount of water, maybe 3 milliliters of water. Flush between that, then administer your next medication and put that in and do a little bit of water flush, okay? And the reason why you don't want to mix your medicine with your feeding is that we don't know what medications may cause what we call precipitation, or it can cause the medication to harden with being mixed with that formula, and then the baby doesn't get the medication, plus you might cause some tube blockage. So don't mix them together, give them individually, flush with water in between, flush with water afterwards. Once again, that's helping to keep the G-tube clean, keeping that anti-reflux valve nice and clean so that those two portions stay flushed together, so that it decreases the chance of any gastric formula coming back and up out through the tube. So the other thing about medications is, let's say it's a medication that can't be made liquid. It has to be a pill. Then the pill would have to be crushed. You add a little bit of water and you mix it in solution. You want it totally dissolved. Then you can administer the medication that way also. Any medications that can't be crushed, any medications that have little capsules or little balls inside, those can't be given through the G-tube either. So, but making sure that it's medication that can go through the G-tube, liquid, or pills that can be crushed, and making sure that you're flushing afterwards, because those medications can be syrupy, they can build up on that anti-reflux valve. So making sure you're flushing after that. That is the end of the education about taking care of the G-tube. We talked about the most common things that people have really, parents' concerns. I change this every time I hear a parent concern that I wasn't aware of before. I will always add that because I figure if one parent has a concern about it, then all parents eventually that question will be raised for them. My hope is that we will be able to meet and I can answer any other questions that you have. This is just a general education video for parents. Realizing that every child is different and things need to be catered sometimes to the individuality of your child and what's going on with your child. So this is just general, and we can individualize things as needed when we meet together. If you have any questions or concerns regarding this G-tube within the first 3 months especially, we want you to call our office first. We desire to be very hands-on in those first 3 months with that G-tube, so please give us a call with any questions or concerns related to that G-tube.